Welcome to the HFMA Talk podcast, the podcast for NHS Finance. I'm Alex Hunt, Content and Social Media Executive at the HFMA. In today's episode, we're going to be looking at the Virginia Mason Production System, also known as VMPS, and how it has been implemented at University Hospitals Coventry and Warwickshire NHS Trust. The focus of VMPS is on eliminating waste, reducing variation, and putting the patient first in every process. The impact of VMPS has been reduced waiting times, fewer errors, and more time for patient interaction. It has become a widely studied example of lean healthcare, influencing hospitals across the world. Today we'll be talking to two clinicians from University Hospitals Coventry and Warwickshire who are at the forefront of this system. Marie Fogarty, Group Clinical Director, and Lynda Mott, a modern matron. They'll share how it has been implemented in the hospital and give real-world examples of how it works in practice. If you'd like to find out more about the Virginia Mason Institute and production system, the HFMA is hosting a 2-day study tour at University Hospitals Coventry and Warwickshire NHS Trust this October. We'll include a link to that in the show notes. Let's get into our conversation with Marie Fogarty and Lynda Mott. To start us off, briefly, could you tell us a little bit about your role and what your day-to-day work typically involves?
Yeah, so my name's Marie. I'm a nurse. By background, I've been a nurse for around 20 years now. I came to UHCW in 2012 as a Band 5 nurse and first time that I started to work within the emergency department, an area that I always wanted to work in. I sort of took the opportunity whilst I was moving organisations to give ED a go and came and sort of started my journey here at UHCW in 2012, and since then I've been on quite a journey around leadership, working within the emergency services footprint, but also around the rest of the organisation in a few different roles. Currently I'm the Group Clinical Director for Emergency Medicine, so that mainly covers front door services, so it's our emergency department, our children's emergency department, our acute services, which includes some inpatient areas, some same-day emergency care areas, and also some urgent treatment centres.
Hi, I'm Lynda Mott. So I am a modern matron for renal services at University Hospitals Coventry and Warwickshire. I think generically a matron's role is a bit of a balance between operational pressures and maintaining quality and safety within clinical areas. So no 2 days are the same. So my days fluctuate. So some days I'll be in attendance at board rounds and we're identifying patients for discharge, encouraging sort of the MDT approach around getting patients ready, whether that's discharge teams to be involved, medics writing TTOs day before in order to try and, have impact on sort of flow throughout the organisation and improve that. Every day we look at safer staffing within clinical areas. So we're always making sure that we're maintaining at least a minimal level of staffing to keep patients safe within the areas. We're looking at rosters, approving annual leave. So although we have managers managing particular areas, we have senior oversight of them and do full approval of these rosters, and any requests for bank shifts have to be approved by matrons. We have obviously daily, weekly, monthly audits, so they sort of factor in throughout the month. So some of them are cleaning audits because we're on the wards making sure that we're maintaining infection control standards. We look after staff well-being, so a huge varied role for a modern matron.
For listeners who may not be familiar, how would you describe VMPS in practical terms from your clinical perspective?
So from a clinical perspective, my understanding of the Virginia Mason production system is all around improvement, and it's about looking at ways that we can improve services that we offer to patients, but also improve our working environment to make our staff happier, improve staff well-being. It also falls directly into what we see as value and waste. So what value do we offer to our patients, and what waste could we eliminate to make giving that value even better?
So for me, it's a standardised approach to when you've got a problem or you need to tackle a challenge. It's a standardised approach that we all collectively can take in approaching that change or that challenge, etc. I think it's always frustrating when you've got two people coming at a challenge in different ways. Well, myself as a clinical leader, a Band 5 nurse on the shop floor, a junior doctor, our cleaners, the rest of the organisation outside of the group, whenever we've got a challenge, we can all approach that in one standardised way. So people are consistent with that, and equally our direct care team know what to expect from us when we've got a challenge or we've got a waste, etc. It's always going to be approached in the same way.
And when the Trust first introduced the Virginia Mason production system, what was your initial reaction, especially as a frontline clinical leader?
Yeah, well, at the time I was a Band 5 nurse. I think at first I was probably a little bit overwhelmed, would be fair to say. I was a junior nurse that probably hadn't been involved in an improvement methodology before. And I probably, my experiences of change and tackling problems was probably sort of like, here's a problem and this is what I'm going to do and this is how I'm going to tackle it. And maybe a little bit of kind of like, I know best. When all the tools were kind of put out to us, I probably had those natural thoughts around, how am I going to use these? How am I going to implement these? I think the program itself really started to develop me as a leader when I started to really understand how to use those tools. It really gave me a deeper understanding of actually not just how to embed a change and how to tackle a challenge, but how to do that incorporating your team and naturally will bring sustainable change. It will mean that it was embedded within the team because the team have been involved in that change.
So for me, when they first introduced the VMPS into UHCW, I wasn't in the post that I am. So I've been in the post for about 3.5 years now. And ultimately, the start of my time in this job was still within that COVID parameter, whereby I hit with a bit of a baptism of fire, really, with, trying to juggle IPC and, I think everything normal wasn't normal anymore at that point, and I think it was sort of a year on. So it was around July 2023 that as a matron and a leader that I became engaged with the processes of that, and I was invited by our KPO team, so our Kaizen Promotion Officers within UHCWI, which are the people that facilitate the sort of collaboration and the way that we roll it out within the University Hospitals, Coventry and Warwickshire's Trust, and I met up with them with a proposal to look at this improvement way of working, which was to introduce a focus board within our clinical areas and to see whether we could embed that into practice. And I would say that initially I was intrigued, would probably be the best way to describe it. I was intrigued because I was always looking at improvement work and I felt like that I was doing my day-to-day job, but the one aspect that I was probably not hitting the mark on was the improvement. But it's having that team that you can collaborate with in order to make it work, I think. And fortunately for me, this was kind of that first glimpse of an opportunity to do that.
Implementing a new system like VMPS can be a major change. How did you bring your team along on that journey? What worked? What didn't work? Did the team require any new skills at all?
So I think we're very lucky that as a trust, as I say, we've got a whole team that work within the trust ultimately to make sure that we implement, the training on the back of this partnership. So they offer like the UHCWI, which is UHCW improvement passport sessions where people attend and they, teach us skills around sort of 5S, which is about, sorting and simplifying processes. And, these can be applied to things like storage rooms. So just making the clinical area more efficient in general by taking something really simple and applying it to make life easier. So I think our staff had really good opportunities and most of them have been trained in some respect towards this. So I think engaging them was actually a lot easier than what people would think. What I would say is the fact that, so Focus Board was our big project and we went along, myself and the ward manager initially, and they sort of delivered a session on Focus Board and what we think that it could achieve. So it's like, go away and have a look at how that will translate into your area. So within sort of 6 weeks of attending the session, we then looked at initiating this sort of focus board, and we'll speak, probably a little bit later about what that's allowed us to achieve. But I think when you first bring something into the clinical area, the first thing that your staff think is we're busy enough, but then sort of, I think because we were enthusiastic about it and we looked at how to deliver it, it kind of then encourages people. and that enthusiasm then continues into your workforce. And then, as I say, later on, once we start to see the improvements that have been made using it, staff start to see the benefits of that, and that engages staff. So I think the thing is keep going. It's not to give up, it's to keep going with the themes, keep explaining, how it's going to make things better. And if you sort of show that bit of enthusiasm, you get that back from staff. So I think the things that worked really well is the fact that we've achieved a lot. The team had, the underpinning knowledge to do it. It was just about collaborating and making it work in practice.
So it's about believing in something and then just making sure that you can bring other people along on that journey with you.
Absolutely.
Yeah, I think the probably biggest tip that I would have is just to be patient. Be patient in, understanding and learning the methodology. Be patient with your team when they're learning it and understanding it. I remember at the time when I was that Band 5 nurse that was learning about the methodology, and I can think back, and it might even still happen now, when somebody comes along and says to you, we're going to change something today, and this is what we're going to do, and you haven't been involved in that change as the person who's going to be doing it. And I remember how frustrating that is. As and still to this day, it might still, it could still happen now, but I know the frustrations that I'd have in that, compared to when I've been involved in that change from the beginning, that I've been part of the solution, I've been part of the PDSA, I've been part of the rollout, I've been part of the communication to the team, and how, one, that makes me feel valued, but two, it makes me want to drive that, make it work. Be part of that consistently every day. And I think consistency is a big part of that. It can be really easy when you're in extreme pressures and you've got to make a change, just like, you've got a problem and somebody says to you, like, we need a solution to this within a couple of days or a couple of hours. It's really easy just to fall back into that mentality of, this is what we're going to do and this is what you're going to do now. And no, it's not always practical to get the tools out and work through every single one of those tools. But that mentality of the core of what the methodology means and how to approach change can be used in any change that you tackle. And it's important that you're consistent with that. If your direct care team sees you as being inconsistent in how you tackle and how you approach a problem, and how you tackle and approach that change process, then they're not going to buy into it. Because they're going to think, well, next time she might want this from us or might want something different from us. It's important to invest and include your team members as part of it. Not always have the same people that are involved in improvement events, Kaizens or RPIWs as we refer to them. Include those people that are involved in it and the people that can come up with those ideas. There's loads of change that we've done over the years, and the direct care teams come up with the best ideas and the best solutions. At times they've shocked me with the stuff they've come out with, and worried me probably at times with the ideas that they've come up with. But actually, by putting trust in them to work through that idea and put it into practice, some of those things are happening now as standard work, because they're the people out there doing it every day. And I think there is an element of basic training required for all teams. Now, that basic training might look different depending on what role they've got, and it could, likely be added to over the years. Recently, as an organisation, we've supported in rolling out value and waste training, just a small 10-15 minute training to as many of us, our employees, as possible. I think there's around 90% of our organisation now that have received that basic training. And so when I go out there and we talk about, we've got a challenge with this and this is how we're going to approach it, and actually use some of that methodology, there's some basic understanding there of the lingo that we might use or the way that we're going to approach the challenge. But also it gets our teams thinking around, what does waste actually mean? Because there might be that common sort of myth around what, waste is about saving money. Actually, it's an opportunity to do things better for our patients. It's an opportunity that when our teams have got ideas or frustrations or rocks in their shoes around things that they're encountering every day with patients or patients' care or making their life easier, they've got a common understanding of how they can go around tackling that.
What changes have you made to processes and patient pathways as a result of the VMPS work?
There's loads of things. I could have you all day, Alex, talking around some of the things that we've done over the years. From really basic things to quite in-depth things. At the start of COVID, we had a challenge in our waiting rooms. 2-meter social distancing was implemented. We had a relatively small waiting room, and at the same time we came off the corridor and stopped doing corridor care for patients, which is brilliant. It's something we're really proud of, but it meant that it was even more pressure on that waiting room area to maintain that social distancing. So we engaged with the direct care teams around how could we make this easier for you in the waiting rooms to achieve this, and one of them came up with this really simple idea of just having a visual aid and having different coloured chairs. So when all the red chairs were all taken up with patients sat in them, and we started to move into the blue chairs, it meant that actually we were no longer doing 2 metre social distancing. We were now at 1 metre social distancing, and it meant that anyone that walked into that area, waiting room, would see visually where we were at with social distancing. It took out wasting our direct care teams constantly being interrupted and being asked around social distancing and where they're at in that waiting room. And that simple idea just came from one of our direct care teams, probably something that I would never have thought of. We did a lot of work a few years ago around sepsis. So the group actually ran a week-long RPIW that included medical, nursing, operational teams, all of our teams. And they came up with lots of different ideas, but one of the things that they came up with was to actually have a SORT team, as they referred to it. So a medic, a nurse, and a healthcare support worker that carried a bleep. And when they had a patient that met that criteria for sepsis, they would send this bleep out, and the team would descend on this patient, have some standard work for each of them around what they were all going to do at the same time. So the healthcare support worker was taking the bloods and putting the cannula in while the doctor was prescribing the treatment, and while the nurse was drawing up the treatment and administering, everything was happening, and it quite quickly improved our patient pathways and the treatment that they received in the recommended guidance. Probably about 18 months ago, we had a bit of a challenge where we were coming in quite frequently in the mornings, mainly a Monday morning, to some day texts from staff members saying that they'd run out of equipment, that there wasn't an available cannula that they needed, that there weren't enough cups to make patient drinks, and they were running out over the weekend. We were also, as a senior leadership team, given the challenge of a substantial waste reduction target. So we looked at both these and thought, well, we've got a workforce that are demotivated and frustrated because they're spending a lot of time in our storerooms looking for equipment. That's not always there. It might be there, they just can't find it. And at the same time, we've got we need to save some money. Now we know, and I know from experience as a clinical person on the shop floor, that when you say to your direct care teams, how are we going to save money, that is not going to go down well. It's the direct care team, rightly so, want to do things better for the patient. They want to make their working life every day as better and easier for them to be able to give them time back to patients. So this seemed like an ideal solution to actually tackle a rock in the shoe of our teams, by also doing probably a wicked problem and looking at that storeroom. So we actually had a week-long event, which we referred to as our 5S event. We had about 16 members of staff that included nurses, healthcare support workers. We had some porters that were in part of that. We had some reception team that was part of that. We had some medical staff as go-to as part of that. We included we were focusing on the ED waiting room, storeroom, but we included some of our acute team as part of that as well. And they spent a week working through the 5S process, and really looking at that storeroom. Now, at the start of the week, we challenged them and gave them a list of about 12 items in the storeroom to go in, and timed them finding these items. It took them about 13 minutes to find all of these items. By the end of the week, when they'd been through the whole process, the same items, which we did get somebody else to do, so it wasn't the same team who now were experts at our storeroom. It took them about 2.5 minutes to find these items. But at the same time, we weren't observing staff going into that storeroom and spending ages looking for something and leaving without having anything. We stopped getting the day texts. We stopped getting the frustrations from our direct care team. So far, we've equally saved money. So we've saved around £50,000 by just not ordering stuff that we never used, ordering better products from feedback from the teams.
We have made lots. So there's probably too many to mention. So for us, we have a discharge lounge at University Hospital Coventry in Warwickshire, and that should enable us that when we've identified patients for discharge, it should enable us to send patients to there in the morning that are waiting on things like, tablets to take home. So we call them TTOs here, or they're waiting on patient transport to get home, which gives you a 4-hour window. So rather than waiting 4 hours for them to be picked up from the ward, they can go to the discharge lounge to wait. And what it allows is those patients that have been in an ED overnight or, sat in the acute footprint that need a renal speciality bed can move up a lot quicker. They then get senior review on the day. And what you tend to find is that we get, you won't experience such a delayed discharge because of the fact that they'll get senior review. They might well then have a really robust plan and be out within 48 hours. So it increases sort of patient turnover and gets people home quicker, which is, ideally what we want. It really helps in that process. So we started off with utilisation of a discharge lounge of about 1 patient per week we were sending on Ward 50. And we did a focus around it, and we sort of broke down some of the barriers as to why we don't engage with being able to send patients there. What is the blocks to that? And within a sort of 4-week period, we then went to 10 patients a week go into the discharge lounge just through having a specific focus on it and engaging staff and having communications with staff. So that was a real, positive. We also then did a focus about TTOs. So as I said before, that's tablets to take home for patients done the day before with the medics. So we got the medics to come to a board, and we did one particular SHO was doing a bit of a project. So they decided that they'd sort of, join up with us, which was really good. And we went from 18% of TTOs being written the day before to 50% within a 5-week period. So there have been a couple of the successes around flow for us within Ward 50 particularly. And then, again, with anything we focus on, we tend to find that we make an improvement. We might well, we can track it for 2 months. There might be the odd time where we'll see a bit of a dip and then we'll go back up again. And it's really, really nice to know that just that concept of using a tool that's so simple makes such a difference.
And I guess in a way you have kind of spoken about the patient experience, but if you had anything to add to that, have you seen any direct impact on patient experience or outcomes since implementing VMPS?
Yeah, absolutely we have. I mean, we had an increased incidence of pressure sores. So obviously that is something that we want to avoid in hospital. So we have our audit score on a huddle board right next to our focus board, which is really nice because it kind of feeds in, so we can start to see when something's sort of, not quite right and we need to focus in on it. So we did a big piece of work around, a reduction in pressure sores. And within sort of, a 4-week period, we'd completely decreased the incidence of pressure sores within the area. And it had been things like making sure that we were doing weekly audits, making sure that on every day we were going round. You only have to look at the bottom of a bed to know whether a patient needs a dynamic air mattress to protect their pressure ulcers or not. And it was just that increased focus makes you then kind of change the way that you work and embed into practice that every day now there's a senior nurse, just going round and just having a look at the clinical area, identifying where there was gaps in knowledge of staff and putting on education sessions, making people, offering study days for people to go and attend, like the wound management study days where they talk about pressure relieving equipment, and just, it does make a difference. It definitely has increased, it's reduced patient risks and it's increased patient safety on our ward.
Yeah, I mean, I think I've kind of covered a few differences in patient experience. Sepsis would be an absolute, an absolute one where we saw some instant, in the numbers and in the measurement, but ultimately we know that we were doing things better for our patients. We've probably done some other things on the basis of feedback from patients. So we did see a theme from patient experience feedback around, probably what you'd expect to hear from an emergency department, waiting times, being in that waiting room out of hours, maybe not having access to as much food and drink, etc., that they would be able to during the day when shops, etc., are open. So again, we engaged with what we refer to them as a shared decision-making council. So it's a team made up of our wider multidisciplinary team that come together quite regularly to discuss around wastes and problems that they might identify and how they can support as a council. So we engaged with them, and again we engaged with them around doing that little bit of coaching around UHWI methodology, and they worked through using some of those observation techniques and following through a patient's pathway. And they just did some minor changes, like be really clear around standard work around when patients have been in the department for a certain amount of time, what are the options for getting a hot meal and how would you do that? Just making that really clear with the teams. They were able to get in some different food and beverages for patients that could be accessed at all times of the day. We had some really positive feedback from patients as a result of that, and who would have thought some small changes like that could make such a difference to patients?
And how has the culture of your team changed since embedding the VMPS?
So I think it's been a positive culture shift. Again, I can think back to being that direct care nurse when we didn't necessarily have an embedded improvement methodology about how to approach change or when you've got a problem. And that inconsistency in how people would tackle that or approach change, or even the communication when things were changing. And that at times could be quite demotivating. Our teams now have that consistent approach on how, if they raise a problem or a challenge to us, how we're going to approach that. And a lot of the time our teams might have already done some of that work or might have already started to build up that observation or build up that ideas generation. And really, if they come to us, it's an element of us probably just giving them the thumbs up to carry on and give them that support or tackle some of the challenges that they might have. I think that consistent approach generally makes your workforce happier. It certainly made me happier. It made me more valued. I've been invested in over the years in education and teaching around an improvement methodology. I think we quite often as an organisation have people come and visit us and we walk our areas to talk about what we have in place. How have we used UHWI as part of our everyday practice? And it's then that you really remind yourself on the journey that you've been on and how much you really do use that methodology every day. I couldn't imagine 10 years ago somebody saying to me that you're going to do a huddle and you're going to do a huddle 3 times a day. And I'm probably a bit like, what do you mean a huddle? And I haven't really got time for that. I couldn't imagine now leading and understanding what was going on in my footprint and across the organisation without having those huddles. And for me, our culture as a team is very much embedded, standardised. And, when we have new people that come into our team, it's role modelled without us probably even realising we're doing it.
So positively, that's what I will say. It's amazing. It's had a massive positive effect. We had, as part of our focus board work and as part of the Gemba rounds that happen where we have executive and non-executive board members come up and do Gemba rounding with us. And we were very lucky that, our CEO, Andy Hardy, came up for one of our Gemba rounds with the KPO team. And one of our focuses on our waste wheel was around our storeroom, which was currently sort of located off our clinical area. So if you imagine if it being located off a clinical area meant that the staff were then using a lot of time to go off a clinical area to retrieve a dressing or a bit of tape, or it could be anything that was in these 2 very messy storerooms, I've got to say. And we'd got a disused bathroom which was in the middle of our ward, and at that time we'd got on the waste wheel that the storeroom was a big issue and that we'd identified a really good space for it. The bathroom, even before I came into post, had no running water to it, but actually it was around, could that space be used as a centralised storeroom? and what difference that would make, and all the different types of waste, through motion waste, transportation waste, duplication, that had happened as part of just moving a storeroom. And within sort of 6 months of that Gemba round, we'd got the team engaged and everybody was really sort of hands-on with helping us achieve that. And we did get our storeroom in the middle of the ward, and the staff, I think, then seeing something really positive come from it and giving time back to patients that was previously taken away with them, having to walk off the clinical area, has made a huge difference as well, because they've seen that we've made positive changes because of this.
How has the Virginia Mason production system changed the way clinical teams and finance or operational staff work together?
It's improved collaboration massively. So as I say, we are a very collaborative MDT. So from a clinical perspective, on renal anyways, we've got really lovely finance team, the ops team as well. We now share offices with our operational manager, and she's really good as well. But it's about being able to invite people. So if we want to do a focus around increasing our professional nurse advocates, which are the people that look after staff wellbeing, that receive really good training to look after staff wellbeing on clinical areas, and I think that aids in staff retention and staff being happy at work and feeling supported again. So we invite the team up as well. So it's definitely increased the collaborations across the trust. That's only one example. We invite the research specialists up to come and speak at our board as well about opportunities for research for nurses, which aids in development, and we put it then as a focus on our sort of workforce part of the board. I think, it's definitely just improved the way we work together.
I think it's probably brought people together and made them understand what, the value in everybody's role is when you've got problems or challenge. I think speaking as a clinical person, speaking as a nurse, again, and reflecting back, it's never going to resonate well with the direct care teams or even myself when somebody says to me, how are we going to save money? It is going to resonate with the direct care teams around how can we do things better for our patients? And having that mentality of that is how we approach challenge, and that is how we approach even cost savings. How can we do things better? Is always going to bring us the best success. I think our relationship with that consistency in that approach and that standardized model, from clinical teams to operational teams to finance teams to all of our business partners, we all approach things in the same way, has that shared understanding and vision. Actually, we want to do things better for our patients. And I think that's only naturally built those relationships. Our finance team are a key person, a key partner when we're having any of our RPIW or Kaizen events, because it's really important to measure what we're doing in a sense of, and it's not just about identifying how much money that we've saved. It's about having a metric that we can positively share with our teams. To be able to say, we've improved our sepsis delivery to patients by 20%, or, that storeroom, not only have you managed to sort it and organise it into a way that is convenient and gives you time back to the patient, it's also saved £50,000 that can go towards better experience for our patients, better experience for you as a workforce. And how we use that metric is really empowering for our teams. So I think it's given us a shared understanding, and it's only ever could build that relationship that we have with our finance teams.
That's great. And how is good practice shared with other teams and specialities? Lots
of opportunity for sharing. I think I've already mentioned around, we have quite regular huddles, not just within our group, but across the organisation. I think probably answers the question before slightly as well, but it brings people together. So we start our day with our nursing, clinical, operational teams, our support staff. We have staff from outside of groups, our mental health trust, our radiology teams. We all come together to huddle. As part of that huddle, we always standardisely reflect on, what went well yesterday and what didn't go so well. So it gives people an opportunity to be positive, to celebrate, to reflect on yesterday and say, this was really good. We need to do this every day. How are we going to do that every day, and how are we going to bring that forward? And that, spans over our whole of our team, that gets shared across the whole of our team. And equally, we can reflect on yesterday and say, this didn't go so well yesterday. Actually, we had a 45-minute ambulance delay because actually we could have done this a little bit better in that pathway. It makes sure that team today is reflecting on that, and we're putting immediate change and immediate solutions and ideas generation into, well, how do we stop that from happening again today? That's really powerful to start your morning like that, instead of it all being doom and gloom. Or even like if we rewind 10 years ago, those teams probably would never have got together first thing in the morning. You probably could have gone days or weeks without seeing some of those teams. So it really builds your relationship as a team. So, huddles are a great way of us sharing to, our immediate teams around what's going on. I've talked a little bit about stand-up already. It's just once a week, 10 minutes on a Tuesday morning. It's where we start our day to hear what is going on in other groups. What are they doing? What are they working on? And, we always take away things from that around, could we do something like that? Could we implement that in our group, or should we link in with them? Because we might have a patient pathway that could link into that. That's really good. That should positively impact on the front door. Let's bring that to huddle and make sure people know that that's going on there. A really good opportunity to share that learning. Whenever there is an RPIW event across the organisation, it always reports out on a Friday, standardly at the same time on the Friday, so everybody knows when that's going to be and when to expect that. We encourage as many of our teams to go to that as possible. Now, it could be something that you might think, it has completely got nothing to do with what's going on for us at the front door, etc. But you always take something away from that, even if it's just the positivity and engagement that you can see in that team that they've done for that week. It gives you that ideas generation around how to use some of the tools that may be into your areas. It gives you that opportunity to hear what's going on around the rest of the organisation, hear around all the positive things that's going on. But equally, if they've had challenge in that process, is there something there that we can support with that? It really gives you that opportunity to share it trust-wide. I think the standardised and the embedded culture of the methodology is a sharing mechanism in itself. A lot of us as team members come together once a week with our peers from across the organisation and have production boards or focus boards where we talk through maybe incidents that have gone on in the organisation that week. What have we learned from them? How can we share that in our other areas? And I might not have heard about it until that moment that I've got to the production board. But I can then take it back to my local production board and share, this happened in surgery this week. This could happen in our footprint. We should reflect on that as well. So those sharing mechanisms are really important and lots of opportunity to share across the organisation.
So we work within a wider team that sits under the medicine directorate. So medicine is quite a big team. This is matrons ourselves. If we find something that's particularly useful, we'll always share the learning within our own groups. We have twice weekly huddles where we sit together, and if there's anything that we've used in practice that we think would be really good for the other areas, we'll share that practice within the matrons. They've also got, within medicine, we have ward managers meetings as well, so the ward managers will take that back. And again, within our medicine team, we have a production board on a Thursday morning that we attend, which is all matrons, ward managers, clinical educators, band sixes, all on there. And we track anything that's happened throughout the week, but we also do celebrations at the end and we share.
How does the Virginia Mason production system approach relate to other initiatives such as getting it right first time and cost improvement programs?
Yesterday, I was on a waste reduction programs meeting with the medicine sort of directorate for care of the elderly, Gen Med and renal services as well. And we are looking at, the projects that we've got currently underway to look at, cost improvements that we can make by doing sort of projects within our own areas. The things that we talk about at our focus board are the things that translate into these projects. They are the projects that become the cost improvements. So we're tracking one at the minute. So we're looking at what we call OSD, which is one-stop dispensing. So that's a bit of a collaboration. So that's between myself and our pharmacist on the ward. Some areas have already, made a really good job of rolling this project out. It was a bit of a trust initiative last year, and it's something that we're really keen to sort of get the ball rolling with. So I think the easiest way for us to do that is to look at tracking it on our focus board. And what that means is we are asking patients now to bring their meds into hospital on admission, and we've got a locker for patients' drugs at the side of the bed, for which the nurse has the keys for. And rather than redispensing a whole lot of drugs to the patients, we use their meds while they're in hospital. And then anything new that we start, we request it as a one-stop dispensing med, which means when it comes up to the ward, it's got the patient's details on, so it's got the name, the hospital number, and it's also got directions, for them to take the medicine. So whether that be twice daily, how much, the instructions for administration on the boxes, which means that when the patient then goes home, that's actually forms their TTO. So rather than then having to send off a 30, medicines TTO, because in renal we have, a massive amount of meds per patient because of, the complexities of renal disease. So rather than doing that, then the patients can take the drugs that are in their locker and they can take them home. So myself and the pharmacist met 2 weeks ago. And we started with a baseline that we look back at January, but that was only to give us an idea of how we're doing with this project. And we were dispensing 63 requests in the month of January. So then for the month of June, because obviously we have to wait till the end of the month to get the figures, we actually tracked at about 131 OSD requests. So we've already shown that we've done a twofold increase in those 6 months without focusing on it. So if we do a big focus on it, and what we will do is we'll use finance, hopefully as well, to track whether the cost related to medications dispensed within Ward 50 reduces at the same time as our OSD requests going up. Because what I would surmise is the fact that rather than the patient coming to the ward and we request a really expensive drug, because some of ours are on anti-rejection because they're transplanted patients and they're quite expensive medicines. So rather than requesting that to come up as just a stock drug that sits in a drug trolley then, that will probably only be for that patient, that we request it just for that patient, so that then when they go home, we don't then have to re-request it. So effectively for one patient, you're requesting 2 boxes of drugs where we could just request 1, which I think will have a massive cost implication. So hopefully that will become a cost improvement. Other stuff was around sort of waste reduction projects. So we talked about the storeroom and the relocation of the storeroom, and that actually, so although there's an outlay for the initial cost of moving that, actually when we did the movement, we found lots of stock that had expired, lots of stock that because it was located off the ward, it just wasn't being, well monitored. So once we moved it to the central location, we engaged with the procurement teams, and we got them up and we had a look at stock levels, and we've had a look at, reducing down or even stopping, ordering stock that we just don't use within the clinical area, and identifying areas whereby we had a box of rocket drains and they're predominantly for respiratory patients. So actually was handing them the box that was due to expire in 6 months' time to the respiratory ward, because we knew we weren't going to use them, to say, do you know what, you use them, because it doesn't matter that it comes out of our pocket. I'm not going to put them in the bin when actually it's a cost saving for you. And we're not just one ward, and we're not just a renal services, we're an organisation, and we should all be helping each other, and then the ask would be if we needed one in, a year's time, that we can just pop down and borrow one. And it's that sort of collaborative working that saves money across an organisation rather than just for a specific area. And I think that's really nice. And I think this partnership scheme, the Virginia Mason scheme, I think that feeds into that. I think it encourages that type of working, and I think it's really effective.
I think it links in with the simple thought, the simple standardized approach of how we tackle challenge or waste or something maybe that we're not quite achieving. Again, when a cost improvement program, it's something that we're all very much living at the moment. Again, I probably have touched upon this a little bit, but how we approach that, how we're going to meet that waste reduction target, for example, is consistent. Every year when we get that, we consistently approach that, and that is with our improvement methodology. To us, that is a challenge. It is a problem. Approaching that with the same consistent approach and using our methodology to work through that makes it more achievable. By doing the ideas generation with our team and coming up with those ideas makes it more achievable. When we're deeper diving recently, we had a week-long program around specifically looking at variable pay. Again, we approached that by using the UHWI methodology. We went into our clinical areas to talk to staff to try and PDSA ideas generation from that work week to get their ideas generation to really understand and get to the root cause of the problem. So I think it's absolutely transferable in any sort of challenge or change or alteration that we've got to make. That methodology is always relatable.
From your perspective, what makes finance a valuable partner in this kind of improvement work?
One thing that I've probably really learned that is important and valuable when you're implementing change is the measuring that's within that. And when I say measuring, it's not necessarily, it is to prove that you've made a positive impact, but it's just such a valuable tool to your teams to say, yeah, you've had to work really hard on this, but look at the difference that you've made. And finance will be a very part of that, to be able to identify that maybe there might be some cost savings within that. Yeah, so really sort of from a finance point of view, absolutely important as part of that. They're part of our team anyway, so part of our everyday teams, part of our support network. They bring a completely different perspective. I think sometimes some of the coaching that you've got to do with your direct care teams is naturally some of their ideas generations at first might be, well, we need more staff, or we could put in additional medics here, or, things that are naturally going to cost money. Actually, a lot of the ideas generation that they come to in the end are things that they can just change how we do a process or how we do something or their standard work in something, which isn't going to cost any money to implement, but will naturally bring some savings. I think finance sometimes can articulate that. They can measure that for us. They can give us a measurable at the end or throughout that we can use as part of that observation.
So I think finance gives us, is a person that's able to track it. So if we're looking at a waste reduction project or an improvement project that we know is going to have a direct cost saving, I think from our perspective, it's really nice for the finance manager if I say from the outset that we're going to look to do this. And then what I would like is sort of, hold a budget meeting every sort of month and we can track how well we're doing with that. Success drives success. So if we're successful at something at month 1, it will drive success to make it better at month 2. And I think that finance have a great place in being involved in that, helping us track those savings across our budgets. And also just being there to sort of suggest that actually, do you know what, have we thought about doing this? Because they have got external insight. They are on the periphery, and sometimes when you're so insular because you're in a, particular department and they come and have a walk around and they'll question things that you wouldn't question because that's your everyday normal. I think they are very valuable, sort of as, on the periphery of the clinical teams to be able to look in and see, what other opportunity are available for us.
What advice would you give to a clinical or operational leader in another trust who's thinking about introducing this system or a similar lean approach?
I would strongly encourage them to do it. I honestly think it's been transformational for Ward 50. I think it's made so many changes. It's created a positive culture, is what I want to say. A positive culture on Ward 50. It's made, us with 0 vacancies. We've made vast improvements. We've done a lot of waste reduction, which directly links to cost. I think it ticks so many boxes, but actually I think we all feel really proud of what we've achieved as well. And I think that sense of pride is echoed through our clinical teams. We've been acknowledged for that as well. We get the opportunity to host Gemba rounds. We have, nationally, we've had people come and visit and we show them our focus board work and we show them in action. It's a live action snapshot of how it actually works within a clinical area. So we show them through our focus board. We talk about the improvements that it's helped. We've talked about how we've reduced so many wastes. So without the collaboration, I don't see that we would have had the successes that we've had. I think it's attributable to the collaboration.
Probably just be patient. You're not going to learn it all overnight. Engage, throw yourself into it. Learn the tools, but don't think that every single time that you've got a problem or a challenge, you have to use every single one of those tools. Really, for us, that methodology is the culture shift that we've already spoken about. It changes you as a leader. It embeds into you around your mentality about how you approach waste. And that might be simply, including your direct care team, how you communicate that challenge or that problem, how you listen to your direct care team, how you observe a process. So be patient, be consistent. If it's a problem that needs resolving right now or a problem that you can work on over 6 months, be consistent in your approach to how you tackle that waste or that problem, and consistent in your communication to your teams and your involvement of your teams in it. And really just buy into it. Take your time, learn the tools, learn from others, observe the processes, and make sure that you include your teams as part of that learning and journey.
Finally, what's been the most impactful or unexpected benefit of using the Virginia Mason production system in your role?
I think I'm going to answer that from probably a bit of a selfish point of view. And I really think it's tailored me as a leader. I think it's shaped how I lead, how I role model, how I engage with my team, how I listen to them, how I tackle when they come to me with a problem, which can feel like it's all the time when you're in some of these leadership and management roles, but how I respond to them, how I include them in tackling that challenge has really changed me. I think if I reflect back, it's really changed me as a leader. I don't think I would be where I am today if I hadn't gone through that journey of learning the methodology and embedding that into me as a leader. I don't think that I probably would have landed in some of the roles that I've done over the years in the organisation. I don't think I would have been able to motivate the team around me to tackle some of the problems that we've had to face. And I don't think we would have succeeded in a lot of that. So I think for me personally, the biggest unexpected benefit is how it shaped me as a leader.
So the positive impact on my team and the enthusiasm that we have for this aspect of our work, as we say at UHCW, better never stops. And it certainly doesn't. And we'll continue to use everything that, that it teaches us to make healthcare and, our service in particular a better place for patients.
Thank you to Marie and Lynda for their insights and examples into the Virginia Mason production system. As mentioned at the start of the episode, the HFMA, along with the Virginia Mason Institute, is hosting a 2-day study tour in October. The tour is designed for NHS Chief Finance Officers and nominated board members to see firsthand how UHCW has implemented VMPS to strengthen daily management systems, enhance quality, and deliver greater value in an NHS setting. You can sign up for the tour via the link in our show notes. That's it for this week's episode of HFMA Talk. Thanks for listening. Don't forget to subscribe so you never miss an episode. And if you enjoyed the show, we'd love for you to leave a 5-star rating on your favourite podcast platform. See you next time.